age groups, but I'll hopefully be able to tailor it a bit
Okay.
to that kind of level for you. Now, most of the children we would see would be in and around that age group. I suppose generally they get referred to us between the ages of 2 and 6, whenever people start to realise maybe there's something amiss with speech or language or fluency, or begin to worry about hearing and things like that. So I'm just going to go over really what communication is for us to start with today. So a speech and language therapist works with adults and with children with a huge range of communication difficulties. Okay? So really we work with clear-to-the-way with kids and with adults. And what is communication? So communication is the transmission of information from one person to another using some type of a signalling system. Okay? So that can be spoken language, okay, which is I suppose the most obvious form of communication. It can also be written language. Okay? It can be body language, facial expressions, gestures, pointing, and it can be sign language for the hearing impaired. So that's what communication is. What is language then? Okay, so a language is a structured system of words which can be spoken, written, or signed, and they're used to communicate thoughts, intentions, experiences, and feelings. So that's what language is. What is speech? So speech then is how we actually communicate with people. So the system of sounds we use and string together to make words and to articulate sounds. So working in a community clinic with young children, basically the children can present to us with a range of different deficits. They can have difficulties in one or all of the areas of mental communication, language, or speech. Okay? So the difficulties we might see in a community clinic, we would have children who have just a speech or a language delay, hearing impairment. They might have physical and sensory difficulties like cleft lip and palate. They might have autistic spectrum disorders, cognitive and learning disabilities, attention deficit disorders. So there's a wide range of difficulties that can crop up in the clinic. Okay? If you have a child coming into you maybe at 2 or 3 years of age, you're usually the first point of contact for that parent and that child into any type of service. Really.
Like when your doctor referred?
Yeah. They'll be referred in either by their GP, in the site it's a public health nurse, but it'll be your health visitor here. If they're school age, it could be their teacher or their preschool teacher. But the parents can also make a referral themselves, and actually a lot of our referrals come from the parents themselves. Because they're generally the first people who are quite astute and realise maybe there's something not quite right. Okay? Sometimes if it's a first child, they mightn't just realise that something's not quite right. They might be up to a preschool teacher or something to point out that maybe the child's falling behind and things, and there are some difficulties there. So where am I now? So children can have breakdown in any of the different areas, so whether that be speech or language. When we talk about language, there's 2 different areas of language. There's comprehension of language. That's our understanding of what is said. So I am currently talking and you are understanding hopefully what I'm saying. So that's your comprehension, comprehending what I'm saying to you. In a child it might be if you give them an instruction like, can you get me the big teddy? Can you get me the red pencil? They need to understand teddy and big and red and pencil. Okay, so they need to be able to understand. So I'll talk to you later about how you build up the complexity of the language and comprehension as well. But that's really what comprehension is. Expressive language then is what we actually say. Okay? So do they have the vocabulary to speak? Do they have enough words? Do they have enough nouns and verbs? So when we talk about nouns, you're talking about objects or things or people. So Teddy is a noun. Julie is a noun. Okay? A verb then is an action word. So Teddy, sit. Noun, verb, Teddy, sit. Julie, stand. Okay, noun, verb. So you need nouns and verbs and then adjectives describing words to be able to build up the structures of your sentences. So children will start off probably just labeling things using nouns, and then they begin to tag on a verb and eventually begin to tag on adjectives, and then begin to throw in the grammatical things, the is, the ings on their verbs, so walking, talking, all of those little things, everything have to be structured into their sentence structures. So they don't just start talking like that, they begin to learn the structures of their language. So where else are we? So speech then is how you say something. So the sounds that you use to say something, and very often children we see in the clinic might have some speech difficulties. So there might be certain sounds that they have difficulty with. Now there is a wide range of what's normal in acquisition for speech sounds. So if a child comes into me at 2.5 years of age and they're not using a K sound, that's fine, because K might not develop until they are between 3 years, 6 months and 3 years, 9 months. Okay? So I wouldn't be working on that. I only work on the sound if they haven't developed it by the time they should. So I'll go through that later with you, what sound should be developed at what times and what to look out for. Other things that we look out for in the clinic are just the child showing signs of having any cognitive disabilities. So you might observe them in the clinic be playing with toys. Are they able to follow simple instructions with the toys? Things like colour can also be an indicator of cognitive difficulties. Do they understand different colours? We look for the social skills as well, and look for any signs of autistic spectrum disorder. Or indeed, is the child hearing me well? Are they having to repeat things? Is there any evidence of family history of hearing impairment? Are they able to sit and attend to a task? Or is there any evidence of attention deficit hyperactivity disorder? Or in case you will see quite obviously if there's any physical disabilities or cognitive or palate or visual difficulties there as well. So I work really with children from birth to 18 years of age, and the majority of children referred into my clinic will be between the age of 2 and 6. And they're referred by the parents of school, the GP or the nurse. And really the first thing we do whenever a child arrives into the clinic is we will greet them up in the waiting room with their parents, try and put them as much at ease as possible, because it can be a very alien environment to a child and it can feel very under pressure. Sometimes maybe they've overheard mum talking about it, taking them to see this speech. It can be the speech and therapist, you're going to see the speech and therapist, and sometimes the child can clam up whenever that's the case. So just trying to put them at ease as much as possible, using kind facial expressions as much as possible, using a lot of tone and intonation in your voice as well, just to put them at ease, taking an interest in the child. You might comment on something they're wearing, oh I like your shoes, or that's a lovely coat, something to kind of put them at ease. And the same with the parent, because they can be extremely anxious coming in as well. When you bring them into the clinic room, I suppose trying to make them as comfortable as possible. If you see them maybe eyeing a toy up, you might ask them if they'd like to see the toy. Okay, bring the toy down, let them have a look at it, or draw a picture or something for you when you're speaking to mum or dad or granny, sometimes whoever brings them along. But the most important thing then is to get started into a case history taking. So what we do is we speak to the parents about the child in general and about the family, and get as much information as we can about them. Because that's going to be of great benefit to us when working with the child and when trying to discover if there are really any real difficulties there. So the first thing I ask is just all the biographical information about the age and date of birth, address, all of that, and then straight into what are your concerns about the child. And sometimes you get a parent who say, well, you're spot on, and well, she can't say her S's yet, or she can't say her S. It'll be something straightforward like that. Or sometimes it can be maybe a child who's not speaking at all. Maybe 3.5 coming to the clinic and not using any language at all. So the parent can be very upset and anxious if that is the case. So sometimes it can be quite a straightforward thing, and sometimes it can be more of a complex issue. So speaking about what their concerns are, sometimes the parent comes in and say, I don't know why I'm here, the nurse said I have to come here. Okay. And that might be because the nurse has picked up something, and maybe it's something that the parent isn't so cued into. Okay. So we speak to the parents, we ask them about the child, what about their developmental milestones. We ask them when they crawled, when they sat up, when they walked. All of these things can be important because if a child has delayed developmental milestones, they might well have delays in other elements of their development, like their speech and language, and it might be acute that there could be some kind of intellectual disability there. Or perhaps a very significant speech and language impairment. Okay, and that's why we always ask about those things. Also ask about the medical background of the child. So have they had any issues? Have they had any issues with their swallow, reflux, things like that? Have they had any issues with their hearing? So those would be really important questions. Ask, have they had a history of ear infections? Because that can always be an indicator that there's difficulty in ears. Do they have very waxy ears?
One of the things is glue ear.
Yes. Okay. Yes, glue ear is basically it's wax in the ears that blocks the ear canals, and it stops, just makes what the child hears, I suppose, able to hear the full spectrum of sounds, especially high frequency sounds like S's and F's. Those are very high frequency sounds, so they can be more difficult to pick up. And it's kind of what the child hears, nearly what you would hear if you know, with big hands on your ears, kind of very muffled sounds. Okay. So what happens with glue ear is sometimes they leave it and see, because sometimes they can unblock themselves. And if not, what happens is they get wee vents or grunts inserted into the ears, which unblock those, and then the child can hear well again. And if a child's needing vents or grunts, what we do is sometimes we can delay the therapy of input if it's for speech sound work, just until they get those fitted. If they're not hearing well, it can be very difficult for them to hear the difference in the sounds and things. So grommets is a big thing that we do check. Hearing is a huge thing for us. So what we do is make a referral on to either the GP to look into the ears, you might refer on to ear, nose and throat, or to an audiologist to check what the levels of hearing are, and if those are appropriate for being able to hear all the different speech sounds and different frequencies of speech sounds. So other things we ask about is really the family history. Would be any family history of speech and language difficulties. That's really important one. Okay, because we do find that, as with all types of difficulties, things can run in families. Okay, so I have had families where all children have been to speech and language therapy, and I've had families where one have been to speech and language therapy. But if there's a significant family history, there's certain things like a specific speech and language disorder or impairment. That's when the child is extremely delayed. That can be very much a positive family history. And some little families with that, it's likely you're going to have another. Stammering is another one. Significant family history. Yeah. So those are the questions you have to ask. And again, a lot of these things run more predominantly more on the male sides of the family than on the female sides. Okay, a lot of our children in the clinic are actually male, and that's the same with a lot of disorders. Actually, it's not to say you don't get females, but it does predominantly males. We also will ask the parent how the child is social. How do they get on with their peers? If they're preschool child, how do they get on with other children? Are they making friends? Are they able to play? Are they able to take their turn? That's a really important thing for just their social skills, and for looking, and maybe also really like that there might be any type of autistic spectrum disorder or even learning disability as well. Because very often even children who can't communicate very well, who might have some type of speech difficulty, can actually communicate very well with gestures and pointing, can actually get their point across very well without using spoken word. And you'll get a lot of children who can actually make themselves very well understood to you without using a single word. You know what they want, you know what toy they want, whether they're happy or sad, they're using good facial expressions and things like that. If your child isn't using that, that would just be an alarm bell for me. You need to have good pointing, natural gesture, facial expression. Eye contact is huge. When you speak to them, will they look at you? Will they look back? If you watch them, will they look back at you? Are they happy to take a turn in an activity like that? Are they happy to engage with you in things that aren't involving language? Okay, so you take the pressure off the language and just see if they're happy to play with you. Okay, that's a really important thing. We're going to talk a bit more about that. So once I've taken the case history, what we're going to do is observe the child. So while I've been taking the case history, I will have been observing the child playing in the room or drawing a picture. So observation of the child is a really important thing. So even through doing that, getting down at the child's level is a really important thing, and playing with them as if you were a child. Okay, so you're going to get down and engage with the child as if you were a child. And from that, I can informally kind of gauge their level of understanding. So I might be playing, and I say, they might be playing with blocks, filling them up. I might say, can you get me the red block? Can you get me the blue block? Can you get me the green and the yellow? So then I know what colours. We might have something of different sizes. So I'll be careful about the toys I put out. So I'll be using things that might give me colours, sizes, so I can kind of decipher what level the child is at. Normally I bring a few things along with me. Sorry guys, I'm on maternity leave, so nothing with me at all today, but normally I bring them along and show you what I do. So then I might say, can you show me a big tail? Can you brush Dolly's hair? So those are all simple instructions, but for a preschool child, it lets me know, are they able to understand their colours, big and small, they know the difference between brush, so they know the birds as well, and they know the difference between Dolly and Teddy. Some children coming in just don't, okay? So So observation of the child and playing with the child will let me see that. It'll also let me see if they're using any type of symbolic playing skills. Okay? So if they have got, I might have put the teddy and the dolly out and a bed and a table and a chair. If they, and a brush, the brush dolly's hair. So they know the brush is for brushing hair. They know that teddy goes to sleep in the bed and the cover of them. Some children will just come into the room and it will just be like a typhoon or something, and everything's thrown everywhere and they're not playing symbolically with anything. They're not sitting down, putting teddy in the bed, putting in, giving dolly's hair a brush, maybe feeding teddy. You know, so they don't know how to play, they don't have those very basic play skills, and play is one of the huge precursors to language development. So if your child can't play, it's unlikely that they're going to have the opportunity to acquire and to develop language. Because that's how you learn your language through play, as we all learned. It also, that observation will give me a chance to see what the child might say. So the child might say, you know, her fall down. And I go, right, okay, so she can join words together, that's brilliant. She's got a verb, but she's used her instead of she had. So she's used like a verb. Romance, that was actually. Okay, romance might be an issue there. It also gives me a chance to listen to how she's saying it. So if the child is playing or telling me about something, her mum says, oh, tell Julie what you got. She said, I got a new cat. I got a new cat. Okay, then I go, okay, so we're going to go and look at signs. This child is 4.5, okay, then I have no issue for this. So all of these things you might be able to pick up just from playing with the child or from speaking to the parent. So observing the child and playing with them will help to build up a rapport with the child and put them at ease and hopefully make them more cooperative for the next part, which will be our formal assessment, okay, or informal assessment if the child is not cooperative. Okay. If a child is not cooperative, what we do is just play further with the child and just make as much observation as we can about what their language level they're at, what their comprehension level is at through play, and what their expressive level is at. Sometimes they will have no expression at all. But then we will look at, well, how are they getting their needs met? How are they communicating? Are they showing signs of frustration, anger, which they often do. If a child has no spoken output at all, they can be very angry and very, very frustrated. And maybe just pointing at things and they can't get them, maybe crying, and then you get your tantrums and your difficulties there as well. So sometimes in those cases, what you do to decrease the frustration is maybe to offer choices of things and even to use natural gesture or sign to try and support. So we always speak, we might sign something, you know, oh, do you want ball? You know, ball. And sometimes we try and copy a sign, like we copy actually about the argument to say ball, okay? So informally, we might just have to go with an informal assessment if a child can't sit for a formal assessment. If they can sit, which hopefully most of them can, what we do with younger children is a little toy assessment. So you get out the toys. And generally the assessment just goes up the different language levels. So I start very simply and I have my toys out and I might have a teddy and doll, chair, keys, sock. And I say, can you show me sock? Can you show me doll? Can you show me teddy? Next step would be I'll put more things out, so more distractions. So some children will totally lose it then because just too many things there and they can't cope with that and they can't scream, okay? Other children can cope very well with a larger selection of toys, then I'll ask them for a few more things. Then I begin to add in verbs, so can you make Teddy sit? Can you make Dolly drink? Can you make Dolly stand? Okay? And then you can then move up the language levels and you might then be asking, can you give me all of the buttons? And can you give me the blue pens? So can you show me the happy cat? Can you show me the sad cat? So you're moving up different language levels there. So you've gone from single word level right up. Okay. And then you can make it more complex. Can you give me this and this? Can you give me the happy cat and the sad cat? Okay. So you can really move up and down the assessment. That's, I suppose, with the skill of the speech language therapist is to try and make it as easy or as difficult as the child can. You always start a level below you think the child is, so they get some degree of, I suppose, confidence in the assessment. You don't want to go in at a level that's too difficult for them, so initially, first thing they're going to do is fail. You don't want that. You want them to be able to achieve something, so you build up, and then eventually when they're beginning to struggle with it, then you just begin to you just continue, okay? And you do that in a way of, you're not saying, oh, I didn't get that, okay? It's just, you just say, oh, it's tidy up time. So, with an older child or a school-aged child, we're probably going to sit and do a more tabletop type of assessment with pictures. So again, like that, you're building up at different levels. The pictures might be quite easy to start with. You know, can you show me something you can eat? So the pictures might be 4 pictures, and there'll be an apple, there'll be a set of stairs, a bed, and a sock. And I'd say, show me something you can eat. Hopefully you're going to stay okay. And then you might have another one, show me something that smells nice, and there's a flower, and one of the pictures will give you a point to the flower. But eventually then, it increases in length and complexity. So can you show me the big spotted black and white dog? Okay. So you're adding in all of the different things there. So you're adding your big, your spotted, your black and white, and you have other distractors there. So you'll have a big brown dog, you'll have a little spotted black and white dog, you'll have a big spotted black and white dog. You know, so there's different distractors there, and they have to listen specifically to what you say and point and select the correct picture. Normally I bring that along where it's easier if you see it, to be honest, but you can hopefully get the gist. So that's really what our assessment looks at. So really we're trying to gauge the child's level of understanding. Comprehension is probably the most important thing. The child must comprehend before you can work on expressive language or on speech or pronunciation. Our assessments will also look at actually what the child is saying, so just flipping pictures, handling the pictures. So you will have nouns and verbs and adjectives in those pictures, hopefully they're able to name them. And some of them are more descriptive tasks, can they tell you what's happening in the pictures? Then you get the longer set and structures out of them as well to see what they're actually doing. And during that assessment you'll also be able to hear how they're saying things as well, so if there's any difficulties in speech you'll be able to hear that. So that's really what we do. So once we're armed with all of our case history information, our observation of the child, our assessment of the child, whether that's formal or informal, what we do is then decide if this child needs any intervention. Okay. If we do find that there's difficulties with comprehension or expression or indeed speech, what we might do is we might list them for a group of intervention, work the children of a similar level, we're all grouped together and we work with them. Or if the child is really not suitable for a group, and that's generally those children who aren't showing very good social skills, who perhaps at a very low level, then we might say we want to go first, okay, and eventually hopefully put them in a group. But most children who come into the clinic are able for group work, and a group is nice in that all of the children there have a similar type of difficulty. It's more fun, it's more interactive. Children are used to learning in groups, they learn in groups in school and in play school, and it's nice for the parents as well. Sometimes parents can be very isolated and think, my child's only one with this difficulty. Well, no, they're not. And they see the other parents learning with children, and it's nice for them as well. So groups are a nice way to work with kids. Also, during our case history taken and our observation, we also make a call on whether this child is appropriate for community clinic or if they require onward referral to any other service. So if we query that there might be a learning disability there, we refer on to disability services. If we thought that their social use of language was poor, there's no eye contact, no initiation to communicate, we might refer on to the autism team as well. Okay? Or if we were worried about hearing, we refer on to audiology to have that hearing tested. So what does therapy involve then whenever we get around to it? So again, as I say, it can be one-to-one or in small groups. It's really tries to be as fun and as interactive as possible. So we do different games and activities where children, basically everybody sits on the floor, therapists, parents and child, each sitting on a mat on the floor. And our group, say it's in language, we won't just work on comprehension, enunciation or expression enunciation, we're working with them together. Okay? So our early child language group for a child of 3 might consist of coming in, everybody learning when to sit on our mats, okay, so they might have to learn that. Some children might be good at sitting, some might want to walk around the room. So getting them sitting on the mats, they might get a name tag. Next thing might be we'll sing hello to everybody, so that's so they get to know each other's names, and they get to know our hello song. That also gives them a start to the session, you know, once the hello song starts, our session is starting. Then we might use a ball and try and get eye contact from one child to another. So I throw the ball to a child and then they have to learn to look at the other child and throw it and use their name if they can, but if they can't, they'll just look at the child, throw the ball, we do that for a couple of minutes. And we might do a listening game then. You know, you could have tape with animal noises. You might have your 4 animals out, you might have your sheep, your horse, your pig, your cow, let the tape what you hear. If they're having difficulty selecting the sound from group 4, you might reduce it down to group 2 to see if they're able to do that. And if they're not, even using hand over hand and pointing to the window. Okay, something as simple as that. So you can have a child in that group who's able to select from one sound from the selection of 4. You might have another child who's only able to select from the choice of 2. You might have another child If he's not able to select at all, I need you to go. So it's a skill of the speech and language therapist to be able to cope with all of those different levels of children in the same group. And really, the activities are chosen in such a way that nobody feels that the activity is too easy or too difficult for anybody. Anybody's doing anything different. So then we might move on to colour. So maybe sorting colours. First colours children develop are blue, red, green and yellow. So things like that. So the first step in learning colour would be to match colour. I might lift up. First of all, I might just bring out 2 colours to start with. So our target colour and the contrast colour. So say that's yellow and red. I might lift yellow and say, can you find yellow? So, and see if they can match. So I'm holding yellow in my hand, can I visually match yellow? Okay. Once they can do that, then I might start introducing another one. So we might have red, blue and yellow. Again, can you find yellow? Then can they do it from the choice of red, blue, green and yellow? And then I will take away the visual match. Can you find me yellow? Yellow. Okay. So hopefully they can find yellow. And only when they can do that would I lift up and say, what's this? And then maybe they'll try and say, it's yellow. Okay. So everything is learned in a very specific way. Comprehension always comes before expression. Okay. So we might work on colour. Next thing we might work on is prepositions. So prepositions are use of words like in, on, and under. So I again bring out some toys. You might have teddy, ball, table, and chair. And I might say, can you put teddy on the table? Can you put the ball under the chair? So again, I'm using visual things to try and aid. So we're talking about visual prompts and gestures.
We looked at text cards.
Yes, okay. You'd use those more in the disability teams with the I suppose with the more lower level clients who maybe have no verbal output at all, but certainly you would use that picture exchange. They give you a picture and you give them the other. Absolutely, and we would just use natural gesture. So I might have out the items and say, put teddy on the table. So hopefully when I use the sign on, if they can't do it, I do hand over hand first. Hopefully next time they'll be able to understand what that is.
Do you use hand or sign?
Yes, well we use, in the south we use a system called Love, which is called Makaton. We can all sign. Natural gesture is good. I use a lot of natural gesture. But yes, Makaton and Love would be used. Makaton in the north, Love in the south. And what it is, it's just a single word signing, so your nouns and your verbs. So you know, things like shower, wash, kind of, but you always use the verbal with it. You don't use it in isolation. So it's quite different than British Sign Language in that way, because when people sign who are maybe who are hearing impaired and maybe using British or Irish Sign Language, they don't stick whenever they're saying it. But in the context of bringing on children with their language, we would always use the verbal word with it. And we don't even sign in single signs. Okay? Really. So, where are we? Right. So, basically that's what we do in our groups. So our groups will have very specific aims and objectives, but your children in the group could be at different levels. Okay? So that would just be one of the groups that we might work on in the clinic. So really your child in that group will need to develop their listening and attention skills, their ability to be able to sit on a mat. Hopefully they will develop their language, because hopefully they're going to learn their colours. They might learn the prepositions in, on and under. They might learn the basic animal vocabularies or listening to animal sounds. So all of this is meant to take place over maybe a period of 6 to 8 weeks. So they'll come to the group once a week for 6 to 8 weeks. And then the parents will continue that work in terms of homework activities there. But they're not going to learn all of that in just one session. It's going to take, those 6 to 12 weeks really, 6 weeks in a session and 6 weeks consolidation out of session for them to begin to do that. Because nothing happens just overnight like that. Learning is a continuous process. So that's really what one of our groups in the clinic might consist of. Another type of group would be a speech group. So if they come along to that for 6 weeks, the first thing we do really is we might introduce sounds. So you might introduce, say it's a K group, you introduce K sound, you introduce other sounds. So you might have K, so K, P, S. Introduce the sounds with symbols again, and I would show them how to make the sound. So and then I put the symbols out and say, I'm going to make one of the signs.
So your phonics, is that
yes.
phonics in primary school?
Well, they use probably Jolly Phonics system. What I'm using here is what we call acute articulation. Okay, and it's specifically for children with speech and language difficulties, okay? So really, your hands mimic what your articulators would do. So if you think, right, so my lips are together, they make a put, and then they release. So my hand mimics It's actually the sound for. So really what I would do is put the sounds out. I make one of the sounds and see if the child can hear the difference in the sound. Sometimes when children come in and they don't have any awareness around the sound at all, and they can't even hear the difference in the sound I'm making. Okay, so it's really getting them cued into that initially. So that's the first thing. So we don't go in straight in, get them trying to say the sound. We get them to try and hear the sound, and hear the differences in the sounds first. And only when they can do that, do we then try and listen to the sound. Okay. And for some children, that's quite easy. They can get the sound straight away in isolation. I could just say k, and they go k. For other children, they'll just go, they'll go t, because that's the error that they're using. They're using t instead of k, and they just can't get the placement for that k. So what they might need to do is do a little bit more listening work, or else there's little strategies you can use it. Using tongue depressor, or depressor, sticking your finger down. Just keep that with tongue tipped down. And once they get the placement for it, generally they'll fly in then. But getting the placement can be difficult initially. So once they have the sound on its own, isolated, you build it up. Similar way to the way you build up the language. You do k, that's the vowel. Ka, ki, kai, ko, ku. Then you do k in words, okay? Cat, kitten, whatever. Then you do from words into phrases. I got a cat, I got a kitten. Then into sentences, then into stories, into reading, all that. So it's again a very developmental process. Okay? So it all makes sense, hopefully girls, maybe tell me. So all of these activities are reinforced at home, and home practice is really the key, because coming in to see me for half an hour once a week is not going to make the child change an error in their sound.
So we
get through it, you're really getting half an hour to 40 minutes once a week, which is sufficient in there, because what I'm doing is showing the parent what to do. But the parent needs to be doing it maybe two or three times at home during the day, and morning and night certainly, to be able to change that error in the child's sound system. You know yourself, if you do something once a week, you come back to it, you've forgotten. So you need to do it all the time. So, really, speech and language difficulties can sometimes not be that easy to identify. Sometimes it's very obvious what it is. As soon as a child comes in, I can go, yeah, that's what it is. But sometimes it's hard to separate overall slowness in learning, and receptive difficulties can sometimes be mistaken for laziness or inattention, or just the parent would say, actually, it's just stepping, just won't listen. And sometimes a child uses that to kind of divert attention away from the fact that they are having language difficulties, okay? So children can mask their difficulties very well as well. So sometimes they just copy their peers. I've seen children in classrooms who just, they follow along what the other children are doing. If it's tidy up time, they'll tidy up. If it's go and get the reading book time, go and get it. If it's line up time to go outside, they'll go and do that. But they just follow what all the other children are doing. They don't actually have to understand any language to be able to do that. They just have to be cute. A lot of them are. Okay? So it's really through the assessment and the observation that you really begin to break down exactly what the difficulties are. Speech and language difficulties are prevalent in up to 10% of the population. Okay? So it is extremely prevalent, and they have very potentially damaging effects on the child, on their educational, social and emotional development. And really, the earlier we get to a child, I suppose the more significant an impact we can have on their learning and development. You know, it's much better to get a child coming into the clinic at 3 who's not talking than to get a child at 6 who's not talking, because they've missed out on 3 years of intervention and 3 years of learning and 3 years of social opportunities, and it's no confidence, and everything is affected exactly. So really, things that you can do then to help a child who you suspect might have a speech and language difficulty are make a referral to speech and language there. It's really important. You know, to speak with the parents. Obviously, you need the parents' consent. But if you have any queries about it at all, just get it checked out. Okay? There's no harm getting it checked out. We do not need people on our list who, or see people who do not need speech and language therapy. Only those who really need it will receive. So make the referral and get it checked out. When you're working with a child who does have a diagnosed speech and language difficulty, an important thing to do is to always secure their attention, because sometimes they have a lot of difficulty with maintaining attention to a task, because sometimes they can suffer from sensory overload and get very distracted by noise or distractions. So securing their attention before giving instruction. So if you're working in a preschool setting or in a school setting, calling their name to get their attention, getting down at their level, so you're eye to eye with them, not talking down at the top of their head. Really important thing. So getting down with them, call their name, visual information to support. So that's like your PEC system, or like your natural gesture. So if you're telling them, giving them instruction, you know, if you're asking them to get something from the bag, you might show them what you want to get from the bag, okay? Or you might use a natural gesture, you know, I want your book, you're reading, okay? So that will support them as well. Be aware to try and reduce and eliminate any background noise or other distractions, okay? So if you're given, you know, make sure that at home, I always say to parents, you know, you're not doing the homework with the dishwasher, the washing machine, the whole lot, all at the one time. That's why the TV, the radio, but the child can't attend whenever that's happening. You know, so try and reduce the noise that's distracting them as well. Keep your own language quite simple, okay? Don't, you know, use simple language with the child, okay? And break your information down into chunks as well. So, you know, single step instructions. So you might say, you know, go to your school bag and there you might say, get me a reading book and then bring it to me. You know, so break them down into chunks rather than go to your school bag, get me a reading book, bring it here, and then get me this. You know, it's too much information, okay? Encourage the child to repeat or rehearse key words, because we all do that naturally. I know if somebody tells me, if I go to mum's now and I say, do you want anything in town? She says, I want this. I have to rehearse that in my head. I'll be in the car going, when she wants bread, I'll go through. But we all naturally rehearse things, okay? So teaching the child that strategy is quite good things. Sometimes children don't know to do that for themselves. So even teaching them those kind of memory things, sometimes they're memory deficits as well. So teaching them to remember, so what did I ask you to get? And you might build it up from one thing to two things, maybe then up to three things that I asked you to get. Okay, your coat, your school bag, so rehearse. So that's what you do. You have to say it over yourself. Coat, school bag, coat, school bag. You might find they remember the first two and forget the last, or else they'll remember the last thing you've said and forget the first. Okay, so building up those memory skills as well. Give instructions in the same order as you want them carried out. Okay, so don't start messing up with the order of things. So, you know, if you want them to go next door and get the whole lunch or something, go next door, get the whole lunch. Okay. Instead of saying, maybe get the whole lunch from next door. It's easier to do it actually in the order that you want. Don't be afraid to repeat an instruction for a child, okay? And an important thing to do is let them know it's okay that they didn't understand. If they don't understand, they need to be able to ask for clarification. They need to be able to say, sorry, what was that? Can you say it again? That's a really important thing when working with children, that they're able to have that strategy within their repertoire to say, sorry, I didn't get that, I didn't hear that. Can you say it again? What was that? I didn't. Okay? So, so that in that way they can get their needs met, because they can get their instruction either broken down or repeated. Okay? And when you're working with children, just praise as well. Children respond really well to praise. You can always find something to praise. It might not be to do with their language, it might be to do with that was really good singing, that was really good listening, you know. That was a really good try. Okay? So praising is really important. And guys, I think that's the time up. We're not on and on and on. I'm sure you've got questions for me.
Thank you very much, Judy. That's very interesting.
I'm
I'm sure we've got lots of people who now want to be speech therapists. The last time we had social work, and it was quite interesting, wasn't it? We all thought we'd love to do social work.
No.
So, yes, we have some questions, but I'm just thinking actually the questions we come up with were very much what type of difficulties do you use, what techniques you use. So we've probably covered quite a lot, but check your lists, girls, and see if there's any question we haven't covered there.
Okay.
Right, you have the juicy bits.
Yes, juicy
The
bits.
worst ever.
Well, I mean, I worked in a language class for most of my career, and in the language class, I worked in Dundalk. You get the 7 most severe children language-wise from the entire county, really. The children will come from all different, they might have started school in Enlightened, but generally they would have been identified by their speech and language there, so put forward for a place in what we call a special language unit. Okay? Now these children will all have normal IQs and normal learning ability, but they have very impaired language systems. Some of them will be absolutely non-verbal at school age. So you might have a 5-year-old who's starting school who has no verbal output at all, and will also have comprehension difficulties. So whenever they're not saying anything, you don't even know at that stage what their speech is going to be like, because they're not even saying a single word, okay? So I would have worked with children like that quite frequently. What happens is they come to the language class. If what happens is we have an intake meeting and we decide who would benefit most from the placement, in that who is the most severely disordered child out there. 7 children get places each year. Some they stay for either 1 year or 2 years in that placement, okay, where they receive regular speech and language therapy. Now at the outset I was there 5 mornings a week with cutbacks and things. I started 3 mornings a week. So they get therapy 3 times a week. But a lot of those children can come from basically having no verbal output at all to going back to their mainstream classes after 2 years. Okay. For some children, it's a disability that will be with them throughout their life. Okay, but generally they're able to go back in their mainstream classes. I certainly have seen children at 5 who have no verbal output at all, and who have significant difficulties with understanding simple instructions. My first point would be to work on their comprehension always. Okay, so what I would do first whenever they come in September is obviously observe the child, but I would use a full battery of assessments to get to pinpoint exactly where the most significant difficulties are. But assessments not only show you difficulties, they also show you what strengths the child has. You're not always looking for what they don't have. What do they have, and what can I use to try and get them push them on a bit further. So really what you do is you work on the comprehension of language. When they begin to understand a bit more, then you can begin to add in the express plan, and it becomes to become a bit naturally then. Only whenever they've got some expressive output, then you need to work on some speech as well, and pronunciation with those children. And those types of children can also have a lot of behavioural difficulties. So if you've got to 5 and you can't speak, you might be acting out of it. You might be extremely frustrated, or you could be extremely withdrawn. So all of those things have to be dealt with in the class as well. So really, they benefit from the small class setting. They've got peers there who have similar difficulties, so they're not on their own. They've got a teacher there who's very attuned to what their difficulties is and get intensive speech and language therapy. So they will require a lot of work. I've had children who might be with it for 6 or 7 years. But those would be the very, I suppose, they're in small numbers within our entire caseload. And probably none of you have ever met a child who is as severe as that, perhaps. But they can be extremely challenging. So they have all of those difficulties, their language difficulties, but sometimes that can be really difficulties. The behaviour and their social interactions can be really varied as well.
Great.
Anything else? I did my A-levels here in Newry, and then I went to the University of Ulster at Georgetown, and I started teaching language therapy there for 4 years. At that stage, it was only there and Trinity that did speech and language therapy. It was a long time ago, 20 years now. But there's a lot of other courses opened up now. There's certainly one in Limerick and in Galway, and one in Cork, and they have increased the intakes into Georgetown and into Trinity. 9 years, there's only 20 girls, I think maybe doubled to 40 now. So I did that training, and then when I got my first job, you do in-post training as well. So I would have done like PECS training, there's different, I would have done law, design training, all of that was done postgraduate, so after I had graduated. Lots of therapists will now do swallowing training for working with adults, or very young children who are already swallowing, feeding, eating, drinking, swallowing difficulties. More obvious, I suppose, in your child with a learning disability or with an acquired neurological condition, or again, there's adults who have motor neuron or MS, stroke. Yeah. So those are all types of training that you can do afterwards. But you know what, girls, the training, it's really been learning on the job. The more children you see with difficulties, the better you get at identifying the difficulties and knowing what's going to work. And really, it's only when you start to work. Whenever I qualified, I had a lot of placements working with people, and you know, working with children, and you get observed doing that, you get assessed doing that, and everything's grand and everything. But it's only as soon as you're sitting there on your own and working with them, that's how you learn. And I suppose that's been the best training ground, really, on the ground work with kids. Yeah, I love it. Yeah, I love it. Like it's nice, and it's lovely to be able to, you know, see a child who comes into you with no verbal skills, and maybe leaves your classroom after 2 years and can can have an entire conversation with me, I can speak to anybody, talk, to anybody that comes into the room and is willing to talk to anybody. It's great for the parents because it's nearly the parents, the child might not just realise, but it's the parents, and being a new parent myself, it's just, if I had a child of 5 who can communicate, the toll that takes in the whole family situation, the worries that they have, whenever they come in, has my child got a learning disability, have they got autism, what with this, to be able to help them, that's a nice thing. So it's a nice thing, day and daily, to be able to help them.
Yeah, I was going to say, is most of your cases are successful?
Yes, yes, I would say.
Do you keep them on until they are making it?
Yes, oh yes, we do. Now, what I would say is within the learning disability caseload, which I wouldn't necessarily see so much in the community clinic because there's different disability teams, that can be more difficult because what you're doing is helping a person to reach their full potential depending on what their full potential is. Okay, so if you have someone who might have a learning disability, that's different from maybe someone who is of normal cognitive ability. Do you understand? So it's really what is their potential. So, your aims and objectives for a child like that, or your aims and objectives for a child with autism could be totally different. So maybe you have to set goals and make them realistic and agree those with the parents. And sometimes that can be difficult too because the parents might just want perfection, or they might have expectations of what is realistic from their child. So that can be a difficult thing actually, that's a very good question. And sometimes you have to work with other members of the team. So you in disability teams might be working with a physiotherapist, an occupational therapist, certainly working with a psychologist, and trying to make those parents have realistic expectations from your work with their child and what they're realistically going to achieve, and trying to make that child as functional and as happy and as sociable as possible. But certainly in the community clinic, yes, we keep them until we can get them as perfect as we can, really. Now, for instance, there was a little guy, I actually heard one of my next patients on the radio during the week, and he had cleft lip and palate. He had quite a severe cleft on his palate actually, it's one of the worst I've seen, and he had these files, he must have 10 files, he's had so much intervention over the years from a variety of different therapists, maybe people have gone off maternity or whatever, but it got to the stage where I was the last person to see him, and I just felt he had reached, he was as good as he was going to get. The child was 16, he had been with us since he was probably 18 months, and really we'd done all we could. Now his speech wasn't absolutely perfect, but it was near to perfect, and certainly I think anybody listening to the radio station over there understood what he was saying. Still had some difficulties with his S, but children with cleft lip and palate, depending on their impairment, always happened. So it's knowing when to cut as well. He was kind of getting to the stage where he was getting a bit peeved off the whole thing too. He was getting a bit too old. So that's knowing where to stop as well. But we do try and make the child as able as possible. So when they are really coming out in our assessments within the average range, it's time to discharge. When their speech is within the average range, it's time to discharge.
Do you want to get anything like that for future treatment?
Yes. Yes. You see, it depends on social circumstances as well. Some parents might see the benefit of the treatment. That might be the parent who comes in and says, well, I don't know what I'm doing, or just the teacher said that. There might be the parents who don't bother bringing their child along to the clinic. So we always would offer the intervention, we'd offer the appointment, but those are the ones that don't turn up. And really there's nothing you can do about that. You might hope that they get referred and they get at another stage, but there's not a whole lot you can do. We do get a bit of that. Then sometimes a parent, an overly anxious parent, or I suppose a parent who might be very, very concerned that the child might have a learning disability or autism, sometimes they can hold back a little bit from treatment too, because sometimes they don't want to hear what you have to say. And that's difficult.
Reality is very hard to see.
Sometimes you just need a wee bit of time to accept that. Or maybe you're suggesting referral on to another team, like a disability team or an autism team. So it's how you approach that. I would always be very direct and say, look, I don't know, I'm only one person. I think Johnny needs to be seen by the team. If they have no concerns about him, if they don't think that there's anything to worry about, he'll be straight back here with me. Okay? So I would always reassure them like that. But if there are difficulties, it's best to find out now and then get the intervention from the right place. So So sometimes that helps them as well. I would say, look, and this is true, I send over referrals and I would say 50% of them bounce back to me. But they do hold on to the other 50%. So I try and reassure them about that. So I'm not saying, I'm not making any, just because I mention this to you, I'm not making a diagnosis. I'm not in a position to make a diagnosis on my own. I'm only saying that these are the areas that I've identified. So I see enough risk areas, so I'm suggesting to you that we make the referral. Sometimes they refuse for me to make the referral. Okay, that will be a thing that will happen. And what I'll do is then I'll keep coming back to it, and eventually, if I'm totally convinced, I say, and this has happened in the past very few times, but I have to say, what I'm having to do here is tell you I can no longer continue treating your child because he's not from my cells, he's from my cells. That might be 6 months down the line. It's only happened once or twice. Generally, you get them talked about. It can take time, you know. Sometimes, if mum's in a row, she can get upset or that. So sometimes when you bring them both in together, or maybe a granny comes along, sometimes the voice of reason can respect that.
Any other questions, girls?
There's a huge range of children that we see in adults. I mean, it is. There's so many different diagnoses out there, and so many different types of patients that we would be active with.
We have a good question here. How do you get them to do what you want? Because we've done a little project on building relationships,
Right.
and how important a positive relationship is, and that comes into, how do you get them to
Have to be very manipulative parents.
Yes.
Yes.
do you use sweets?
No. Absolutely not. No. I'm always quite firm, actually. I don't know. The girls laugh at me because I would be quite firm, but it'd also be fun. How do you get them to do what you want? Some will come in and they'll just wreck the place, you know. It depends on the child. If they're a child who's very distracted and just only want to follow their own agenda and do their own thing, what I do is I clear therapy room out completely. So I have no distractions in it, I have no toys within, sometimes they're climbing up the walls, out the windows, everything. And I might just bring out 1 or 2 toys or a couple of toys in for a child like that. So that's your child who's maybe more bouncy and just only wants to do their own thing, okay? So reducing distractions in the room and making it very controlled, allowing them to choose a toy from the box, but only playing with it for a short period of time, and then building up the length of time that they can sustain attention with that toy. Another child might come in and they're just innocent, so they're just don't do it, okay? Sometimes you have to work with mum, so me and mum play the game, okay? And sometimes if that's a lot of fun, big fun, then they'll want to play, okay? And so that's another strategy you use. Sometimes taking the pressure off what they're there for. So I have had to, if they're there to do speech work and we're maybe on a production task, if they really don't want to do that, we might just do a listening task. Okay, so really don't have the point that the pressure isn't on the production part of it, it's on the pointing. Okay, so that takes the pressure up there. So, or I go into the level below the level they're able for. So generally, that's an important thing, as I think I mentioned earlier, getting them a level where they can succeed first. That you're not going to straight something that's really challenging straight away. So always warming up with something a level below where they're at. So they're able to succeed, and that was great. You give them lots of praise and encouragement, and then you can begin to introduce the things that you want to do. So sometimes it's about doing things that really aren't getting you very far in your therapy, but might be getting their cooperation. Or sometimes I've had to go back and just do an entire play session, which just allows me observation of the child because they won't cooperate with anything or
thank you very much. Any other questions, girls? I think you've covered everything.
I think I'm probably wrong.
No, I would say it's very interesting. A lot of those things we've actually mentioned, they've all mentioned in the coursework the importance of getting down to the level of the child, using eye contact, things like that, visualize, all of that. We can talk about it.
Don't be afraid to break things down and repeat them.
Yeah.
That's really
And short instructions.
And teaching your child strategies to help them ask, so they're able to ask, sorry, what was that? Say that again, that they know to put their hand up to make themselves, because otherwise they just get lost in the classroom situation and nobody knows that they haven't understood. And then maybe they're seen as maybe being a good child, or the child just won't do what they're told. When actually they won't do what they're told if they can just remember what you really have to say.
Yeah.
Okay, so.
Yeah.
Your community-based, but do speech therapists go into the classrooms?
Yes, I worked in the language class for many years, and that's within a mainstream school. But we used to, well, I don't know what happened in the north now. We used to get a lot more input of us going into schools, especially more private areas, because sometimes they're the kind of children who wouldn't show up at the clinic. But still very much need interventions you might get in the school. So there would be very often speech therapists who would be in schools for children with special needs, so they would be in there, but in the mainstream schools not so much sure anymore. So it's mainly about withdrawing children into the clinic situation. And that's just complex. It's not necessarily good, it's not a good thing. I think it's best to see children in their natural environment. We used to be able to go out and do preschool visits and watch the children in their creches and things like that. And that's a really important thing for me to be able to see how they interact with other children. But now, so we just have to try and observe them within our own clinical settings. And ask lots of questions and maybe what they don't have